Secondary adrenal insufficiency in the setting of PD-1 therapy. Presented by Polina Geisenskaya, MD, Jacob Komberg, MS4, Catherine Reno, MD, and Biraj Shah, MD, from Florida Atlantic University. Immunomodulators such as pembrolizumab, a programmed cell death protein, also known as PD-1 receptor inhibitor, have a range of adverse effects including gastrointestinal, hepatic, dermatologic, as well as endocrinologic. Although endocrinopathies are commonly associated with immune checkpoint inhibitors, adrenal insufficiency has been found to be very rare. We describe a case of secondary adrenal insufficiency resulting from pembrolizumab. A 60-year-old female with a past medical history significant for lung cancer on pembrolizumab for 3 years, COPD, and hypothyroidism presented to the emergency department with pleuritic right back pain. The pain was associated with nausea, vomiting, decreased appetite, diarrhea, generalized weakness, and cough productive of green sputum. Patient denied any fevers, chills, or shortness of breath. On admission, she was found to have significant hyponatremia. Patient also initially had a positive Murphy sign on exam, but subsequent imaging with right upper quadrant ultrasound did not reveal any stones, sludge, wall thickening, pericholecystic fluid, or duct dilatation. The patient was started on empiric antibiotics as well as intravenous normal saline. During her hospital course, the patient developed worsening abdominal pain and weakness. Her hyponatremia was minimally responsive to normal saline, and an abdominal CT did not reveal any intra-abdominal pathology. Infectious and metabolic workup were unremarkable. She was found to have an AM cortisol of 0.6 micrograms per deciliter, and her adrenocorticotropic hormone level was 2.4. She had poor response to a concentropin simulation test indicating possible secondary adrenal insufficiency. She underwent MRI for pituitary assessment, which was unremarkable, and her other hormone levels were within normal limits. The patient was initiated on hydrocortisone and subsequently had rapid improvement in all of her symptoms, as well as her hyponatremia. She was thought to have isolated secondary adrenal insufficiency, likely due to pembrolizumab therapy. According to past reports, the incidence of adrenal insufficiency has been found to be less than 4.3% in PD-1 inhibitors. ACTH deficiency and hypophysitis have been reported in patients treated with a different PD-1 inhibitor, nivolumab. It is hypothesized that the underlying mechanism is autoimmune in etiology. Isolated secondary adrenal insufficiency is exceedingly rare with PD-1 inhibitors. The necessity of recognizing the nonspecific symptoms associated with adrenal insufficiency with patients under immunomodulator therapy may aid in preventing detrimental outcomes such as adrenal crisis. Here in Figure 1A, you can see the abdominal CT without any adrenal abnormalities. And in Figure B, shows patient's brain MRI without any pituitary abnormalities.